Hi, welcome to my video on hormone basics. I'm Dr. Shana Johnston. I'm a family doctor in Victoria, British Columbia, and I prepared this video on hormone basics to give a general overview of just some of the basics of hormones. There is so much to say about this, which is why I've actually created an entire course called Empowered Menopause. And so I will get into the details of a lot more of these things in that course, but I wanted to give a high level overview of hormone basics, just that was nice and accessible for everyone to take a look at. Having said that, this is intended for a Canadian audience. It's all Canadian products, and so anything and as with anything I say in any of these videos, this is menopause is a rapidly emerging field. This has been a highly understudied field. Women's health in general has been highly understudied for a long, long time. So we're rapidly catching up, and so this is a rapidly changing field. So I'm presenting my current understanding of the evidence that I've currently been able to access and be able to understand and read through, and is a rapidly evolving field where there's lots of new stuff emerging. So what I have to say does not substitute for the individualized consultation with a one-to-one consultation with a knowledgeable menopause provider. I do recognize those are hard to find, and so that's why I want to give you a general overview, so to help you get a basic understanding and to help you advocate for yourself. And if there's anything that doesn't feel quite right, please get it checked out by a knowledgeable menopause practitioner. And sometimes that even is getting into the private pay space to be able to get those resources, but just to make sure that you are getting the knowledge and information that you need so that you can get the care that you do need. So we'll get into it. So in terms of objectives, I'm going to briefly discuss the safety of menopause hormone therapy. As I mentioned, I get into this in way more detail in my course Empowered Menopause. So there's a much longer video that goes into that more, but I'll give a brief overview, and I'll do a brief review of the physiology of the hormone changes of menopause, just to help give us a grounding for what we're going to talk about next. And again, I get into that in more detail in the Empowered Menopause course. And then we're going to talk about the basics of menopause hormone therapy. We're going to talk about progesterone first, then we're going to talk about estrogen, and then about testosterone. So in terms of safety, like I said, I have a whole video on this, but just in a really, really tight capsule summary, menopause hormone therapy has actually been around for a long time. It's actually been around since like the 50s and 60s. We originally only had Premarin and Provera. So Premarin was the estrogen, and then Provera was a synthetic progesterone. And the two of those that's what we had available when I graduated. So it was actually fairly easy. That's all there was. um, and it helped a lot of women. It really helped a lot of women. And one of the challenges is that we were overusing it, though. So I think that's sort of what led to what happened in 2002, which was this media sensationalism, misrepresentation of data. Like, things were just really, it was not good science the way this was reported. And it was more of a media storm, sensationalism kind of thing that basically they misrepresented some of the data. Some of it was that the way the study was designed is they were actually studying women 50 to 79 with an average age of 63, which is not who we're really talking about. We're talking, like, when we talk about menopause hormone therapy, we're talking about women in their 40s and 50s, not women in their 60s and 70s. And so part of that is where some of this all of these some of these conflated risks came from, and some of it was misrepresentation of what the data actually showed. And again, I get into that more in the video on specifically on risks and benefits of hormones. But basically, in a nutshell, what we know now is that hormones are generally safe for most women if they are started in the window of opportunity. So again, there's exceptions to this, but for the majority of women, if hormones are started within the window of opportunity, so within 10 years of the last menstrual period and less than 60 years old, for the majority of women, they are very, very safe. They can be started outside that window, so they can be started at greater than 60 years old and greater than 10 years after the last menstrual period, but they do come with increased risks. And again, I talk about that more in the video, but that just to be aware of that. In terms of hormone physiology, I'm going to just briefly go over this, and again, I go into this more in the other video, but just to give you a high level summary. Basically, when we're born with all the eggs we're ever going to have. And then when we hit puberty, there's messages that go from our brain to our ovaries to turn our ovaries on. And then we go through a bit of a hormonal storm at that point, and then we start having a monthly cycle. So the beginning of every month, we recruit a number of eggs from the ovary, which releases estrogen. At the mid-cycle, we ovulate the best of those follicles. The best egg is then released. The little cyst that's left behind is called the corpus luteum, and it makes progesterone for the second half of the cycle. And then if a pregnancy doesn't occur within that cycle, then 14 days after ovulation, the corpus luteum slowly disintegrates over that time, and by then there's no progesterone left, and both estrogen and progesterone fall off, like the hormones fall off, and then we get a bleed, we get a period. And so there's a normal ebb and a flow to our cycle every month. Estrogen primarily in the first half, progesterone primarily in the second half, and it kind of just ebbs and flows. And there's sort of a rhythm to it. Then what happens when we arrive at perimenopause? So as you can see in the slide here, that there's kind of like that ebb and flow all through our reproductive years. And then in the early part of perimenopause, what happens first is the progesterone levels start falling. Testosterone is also falling at this stage as well, but progesterone levels start falling because the corpus luteum, the little cyst in the ovary, isn't as juicy. It's like, because our eggs have, by this point, our eggs have been around for 40 or 50 years, so they've passed their best before date. And so what's happening is that that little cyst is less juicy, so it's not releasing as much progesterone, and therefore our progesterone levels are relatively lower. So we actually will start getting a lot of symptoms, like PMS type symptoms, of that, particularly in the second half of our cycle, when that's normally dictated by progesterone. Those are the first symptoms we'll often get, is those PMS type symptoms in the second half of our cycle from the dropping testosterone. Meanwhile, our brain is trying to tell our ovaries to work even harder because it's kind of losing ground. It's like, whoa, hang on, try harder, girls. Come on, you can do this. And what happens is that initially we actually get much higher levels of estrogen, which can then cause like symptoms of like headaches. It can cause breast tenderness. It can cause all kinds of like sleep disturbances, mood changes, anxiety, like all kinds of different things. So that's in the first part of perimenopause, like in the early perimenopause. So there's actually, in some ways, there's too much estrogen, and then dropping progesterone, and then, like I said, testosterone is made by the ovaries as well. And so, meanwhile, it's just kind of slowly declining during this time. So the early part of perimenopause, you have a little bit too much estrogen, and it's very up and down. So that's why testing is very challenging, because it's just all over the map. So it's not all that helpful, because it's just like, how far is the roller coaster off the ground? Well, it depends when you measure it. Like it's up there a second ago, now it's there, and now it's there. So it's really tough to use those as a measure, because they're rapidly fluctuating. As we move through perimenopause, we get so our ovaries are working harder and harder and harder, but less and less and less estrogen is being made. And so we still get those fluctuating levels, but they get lower and lower and lower. And this is often a good time for estrogen to be started, it kind of helps to buffer some of those fluctuations a little bit, and then also to bolster just those lower concentrations as well. And then once we move through menopause, so menopause is 1 full year with no periods. But it's still, so from especially the year or two before till the year or so after is a very tumultuous time. There's a lot of hormonal shifts that are happening around that time. And that's when most of us benefit the most from being on menopause hormone therapy, because that's when things are like all over the map. And then slowly over time, as we get further and further from that last period, then the levels start slowing down, and there's often less and less symptoms, although some of the symptoms can persist, particularly like vaginal dryness, and some of the local symptoms, but other symptoms can persist as well, sleep challenges, some of those other things as well. So anyway, just wanted to give a just brief overview of the physiology, and now we're going to talk a little bit about what we can do about it. So we're going to first of all talk about progesterone, because it's often the first one that's affected. So progesterone is it's like the calming hormone. It's the hormone that kind of just it just helps our nervous system to kind of settle a little bit. And we often feel moody when it's low, particularly in the days leading up to our period, when that corpus luteum is really like getting smaller and smaller and smaller, or when we're getting when the corpus luteum just doesn't have is not as juicy. So we're going to just, those are the first things that we're usually going to notice. So this will usually be still when we're having regular periods. We are usually having regular periods. So this is in the late reproductive stage, that we're still having regular periods, or pretty regular. Like there might be a few days off here and there, but they're pretty regular. But often a lot of us will start to get really moody, those PMS type symptoms, especially in the second half of the cycle. And that's usually progesterone kind of effects. And so that's the moodiness, the irritability, the anxiety, the sleep changes, those PMS type symptoms. So those are the things that we'll really start to notice. As the progesterone levels drop lower and lower and lower, the cycles get more and more irregular. And then meanwhile, the estrogen is really erratic, and that's also making them irregular. But particularly as the progesterone gets less regular, the cycles can get more irregular, and then symptoms will kind of increase more and more. So what to do about it? So my favorite is the bioidentical progesterone. And what do I mean by bioidentical progesterone? By bioidentical, I mean it's the same chemical composition as the hormones that our body makes naturally. Versus the synthetic progestins, which I'll get to in a moment, are similar. They're a chemical, like they're both still made in a lab, but one of them is the same chemical composition to what we have in our bodies. The other one is similar, but not the same. So I'll get to that in a moment. So bioidentical progesterone is the same chemical composition to the progesterone we have in our bodies. It's just that it's made in a lab and we take it as a pill. So Prometrium is the name brand of that. So it's micronized progesterone. It's taken as a pill at bedtime. It often has like a calming or sedating effect, because it gets converted to a hormone called allopregnenolone, which works on the GABA receptors of the brain, which basically is a calming. It's kind of like a Valium type effect. So it's a calming, sedating kind of hormone, and so the range for it, usually it's 1 to 200 milligrams, but it can be used 1 to 300. Some people will even use as much as 400, but usually sort of 1 to 200 is common, and sometimes up to 300. And so in the early perimenopause, when you've still got those regular cycles, it's often better to take it cyclically. So you take it day 14 to 28 of your cycle, or you can even just take it on your symptomatic days. You can, like, if you're just really irritable for the 5 days before your period, well, then you can just take it for the 5 days before your period. And the interesting thing is you can take it in addition to, if you have a Mirena IUD or you're already taking progesterone for birth control, you can also take the bioidentical Prometrium to help with those PMSE symptoms in those days leading up to your period, which is kind of a cool thing. So yeah, in the earlier part of the perimenopause, it's better to take it cyclically. Later in perimenopause, things are just so all over the map that you're probably better off just taking it every night. And that would usually be 1 to 200 milligrams at bedtime. When you take it the second half of your cycle, it's usually 2 at a time, but you can try 1 for if it's just symptom control. But if you're using it for endometrial protection, you do need 2 at night for the second half of your cycle. It does not work as birth control. As I mentioned earlier, you can use it in addition to a Mirena IUD. It does, if as long as you're taking it at the appropriate doses, so at least 200 on the second half of the cycle, or 1 to 200 for the full cycle, it can be used to protect the uterus from the effects of estrogen. So if you have a uterus and you are taking estrogen, you need some kind of progesterone, either a Mirena IUD, a synthetic progestin, or bioidentical progesterone to protect your uterus from endometrial cancer. And that's really important. So it will protect your uterus. And it used to be really, really expensive. It used to be like, it was over $400 for 3 months when I first went on it. And about a year ago, a generic became available. So it now only costs me just over $100 for 3 months. So it's significantly cheaper than it used to be. And for those of us in BC, it sounds like it's quite possible that in coming soon, menopause hormone therapy will hopefully be covered similar to contraception. So fingers crossed. I hear a lot of buzzing that's going to be coming soon. So hopefully so. In terms of, so then one of the other options is the synthetic progestins. And so, like I said earlier, it's similar to progesterone, but it's not the same. And so this would be the progesterone that's in birth control pills. So there's like a whole bunch of different ones. There's like 6 or 7 different kinds of of synthetic progestins. They're all just a little bit different. Like, oh, you have too much acne. Okay, we'll try this one. Oh, like different effects that like we'll often kind of play with them with like birth control pills to give one that has like the effects that we do want and not as many of the ones we don't want, depending on how the person is responding. So there is the opportunity to kind of play a little bit with different types of them, with the different synthetic progestins. They don't have that same sedating calming effect of like they don't do they don't convert to allopregnanolone, that hormone I was telling you earlier that has that sedating calming effect. They still do help with like mood symptoms and everything. It's just that they sometimes it's just less pronounced and it doesn't have that sedating effect. There's a number of different ways that you can take it. So Provera was the original one, and then norethindrone is another example. There's lots of different ones. Some of them, like norethindrone, can be taken as a mini pill as contraception. And then at lower doses, they can also be used for menopause hormone menopause hormone therapy. It will also protect the uterus from the effects of estrogen. And it's less expensive than the bioidentical progesterone, but the cost gap is a whole lot less than it used to be now that the generic is available. So yeah, so I still prefer the bioidentical progesterone, but some people do better on the synthetic progestins. So it's really, and there is a lot of different options. So there's different things that you can play with. If you're not tolerating one, you can try a different one and see if you do better. And then finally, the Mirena IUD. So that's the intrauterine device that goes that is inserted by a physician, and it's really good for particularly when when the periods like are getting really bad, like when you're getting those heavy, awful periods, like when I used to call it the period party, like that that just before your periods disappear, they make sure that they get all of your attention. So it can be very helpful with the period control. It's excellent for contraception. It will also protect your uterus from endometrial cancer. The lower dose one, the Kylena, there's not as much evidence for that, but the Mirena can be used for endometrial protection. There's very little of the hormone that's absorbed by your body. So if you're very sensitive to hormones, there's usually very little that you're sort of actually like feeling in your body. And like I said, you can also use a bioidentical progesterone as well if you want to have this for like period control and contraception, but you still want something to help with the sedating calming effects. You can use the two in combination. So just quick little summary of progesterone. So we've got the bioidentical progesterone, which does not work for birth control, but will protect your uterus and is usually really nice for the symptom relief, that calming, sleep, sedating kind of thing. Used to be quite expensive, but now not so much. It's much more affordable. The Mirena IUD, which will also protect your uterus. It can be used, it's excellent for contraception, really, really great for the heavy periods. And it's quite expensive as well, but for those of us who live in BC, it's covered by our provincial health plan. So we're very grateful to the province for that. And then the synthetic progestins also provide uterine protection. Some of them can be used for contraception at the higher doses. You just want to make sure you've made very clear with your provider what your goals are for what you need it for. It can be helpful with symptoms, and it's a little bit less expensive than the bioidentical. And then the one other thing is that the progesterone cream, I do not recommend the progesterone cream. It's not well enough absorbed to provide uterine protection. You might get a little bit of symptom relief from it, but you're not going to get, you won't get the amount of uterine protection that you need if you're also on an estrogen, and it does not provide birth control either. So there's a lot of other better options. So I don't recommend the progesterone cream. So now on to estrogen. So estrogen, as I mentioned earlier, the levels are very erratic during perimenopause. It's all over the map. So initially they're quite high, later on they're falling off. Testing them can be quite misleading because they're so erratic. It's just really hard the testing just isn't really helpful for this. There's two different ways. So there's whole body estrogen, and then there's local estrogen. So whole body is like through the either topical with a gel or a patch, or taking a pill, and I'll get into details of all those. Or then separate to that, there's local estrogen, which is only absorbed locally by the vagina, the vulva and the vagina, and just acts locally and can be started at any age. So I'm going to go through the details of each of those, but I wanted to give you an overview that there's either whole body or local. And then if you're on whole body, then it can be either topical, which like through the skin, or oral. And then yeah, and so I'm going to get into all of those in a moment about what each of those mean. So in terms of whole body estrogen, so it just means that your whole body is getting estrogen. So therefore it's ideally started in the window of opportunity. So within 10 years of the last menstrual period and less than 60 years of age, ideally. It can be helpful for hot flashes, sleep, mood, many of the other long list of symptoms, musculoskeletal syndrome, menopause, like the aches and pains and the whole bunch of different things it can be helpful for. But like I said, you can either do it as a patch or a gel, or as a pill. But it's your whole body on estrogen. And so therefore you must use a progestin if you still have a uterus to make sure that your uterus is protected from endometrial cancer. In terms of so like I said, there's topical, there's whole body estrogen can be either topical or oral. So we're going to go over the topical first. So topical means either gel or patch. So the gel either comes as is bioidentical. So all of the different estrogens are actually bioidentical. So other than if you're taking like a mini pill or something, like the birth control pill has a synthetic estrogen in it called ethinyl estradiol. But most of the menopause hormone therapy is usually 17 beta estradiol, which is a bioidentical estrogen. So it can be applied as either a gel or a patch. And so the gel is usually, so that's either Divigel or estrogel. The usual doses would be either 1 to 2 pumps of estrogel per day, once a day, or Divigel, which should be usually about 0.25 to 1.25 milligrams per day. It comes in a little packet. And so those are the two different ones. And basically what you do is you squeeze out the gel, you put it on, say you're on your arm or your thigh. You give it a good, it only takes a few minutes. They say 5 minutes, but I find it dries within about 2 or 3 minutes. You just want to make sure it's fully dry before you put clothing back on so that you can get the absorption. And you have to just be very careful not to have that skin in contact with a male bed partner, children, pets, for the first few hours after you've applied it, because it's actually quite concentrated and they can accidentally get estrogen. So you just need to be careful of that. The patch is basically like a little sticker that you wear on your skin. It gives a continuous amount of estrogen over the period of time that you're wearing it. The estradiol you would change twice weekly, and the Climera you would change once weekly. The one thing is I find the once weekly ones that don't, when I was on them, I didn't find it lasted the full week, and it would sometimes wear off towards the end. So you might need to change it slightly more frequently. It can cause some skin irritation. The range is usually from 25 to 100 milligrams per day, and it does give kind of a nice level amount. So those are the two types of topical estrogen. And then the other type of systemic or whole body estrogen is the oral. So you can either apply it to your body or you can take a pill. Either way, you'll get it to your whole body. The advantage of oral estrogen is usually it's convenience, just taking a pill. It's often less expensive than the patches or pills, but again, hopefully if we're getting things covered here soon in BC, that will be less of an issue. Disadvantages, there is a little bit of an increase in blood clots and stroke risk, and stroke due to blood clots. So it's a tiny risk. It's a tiny increased risk, but just something to be aware of. The absorption can be a little bit more erratic than topical, and the half-life isn't as long. So I found specifically it was too erratic for me. So when I was taking it twice a day. Because the levels were fluctuating too much for me to only take it once a day. And then the other thing is I only found out like later along the lines is that it, through personal experience, that it increases sex hormone binding globulin, which is a carrier protein for both testosterone and estrogen. And so it'll bind estrogen, but it also binds testosterone. And so it actually lowers the amount of testosterone available in your body. So that's one of the disadvantages of oral, whereas in topical, it doesn't do that. But the oral estrogen can artificially drop your testosterone levels even further. So that just something to be aware of. I didn't know before I started oral estrogen and got to learn the hard way about that. And so different types of it that you can take. So you can either take it as a low dose birth control pill, that's the synthetic ethinyl estradiol with a synthetic progestin. You can also take the Premarin, which is that original one from like the 50s, and then which comes from pregnant horses' urine. Premarin, which is pregnant mare's urine, so that's where it comes from, and it's in a dose of 0.3 to 1.25, usually around 0.625 milligrams. And the most commonly one used would be 17 beta estradiol, which is the bioidentical one. Usually anywhere from 0.5, usually about 1 to 2 milligrams, like often around one to 2 milligrams, but it can be in a range of 0.5 to 4. 4 is a lot, but anywhere from 0.5 to 4. And there is lots of different choices that can be combined with the progesterone. So for people that aren't as sensitive to, like, I'm very sensitive to hormonal changes, so I have a lot harder time with some of these. But for some people that, like, I have friends that are like, oh yeah, I just like I've been just taking a pill once a day. It's all good. It makes it easy. Tickety boo. So for some people, like the convenience and they do well with it, it's great. But just wanting to let you know, I'm just not one of those people. And so just letting you know some of the potential downsides, but a lot of people do very well with the oral. And then, so we talked about whole body estrogen. And then we're also, so the other way of taking estrogen is locally. And so the vaginal estrogen can be started at any age. It does not need to be started in the window of opportunity. It can be started right away, like if you're having, and so what you would want to take it for is vaginal dryness, painful intercourse, because it just feels like everything just isn't stretching as much. It feels more tender, like it just doesn't feel right. Have a very low threshold for adding some vaginal estrogen. Recurrent bladder infections is another one. So anything from the tissues just getting a little bit they aren't as supple without the estrogen. The estrogen helps to make the tissues more supple, more moist, more plump. So I would start earlier rather than later if you are having symptoms. And they put these stupid warnings on it that's like, it causes cancer. It doesn't cause it. It does not. There's a little bit of vaginal estrogen is not going to, like, a little tiny bit that's absorbed should not cause any problems. It's safe it can be started at any age. It can even be, now again, you want to have this as a discussion, but like I have a friend who's an oncologist and she regularly gives vaginal estrogen to her patients with hormone positive breast cancer, because there's so little that's absorbed locally that it's generally considered safe. And because it's not absorbed by the rest of the body, you don't need a progesterone to protect the uterus as well. So you can, let's say you're 65, you've actually made it through menopause pretty well, but you are having a lot of local symptoms, then the vaginal estrogen is a great choice. And you can just use that. You just put the cream on locally. The one thing I would say, so a lot of it, it's like an applicator to put in your vagina and everything. So absolutely go for it. But often the area that's the most sensitive is right at the opening of the vagina. So like right as it's right at the opening. And oftentimes that's what really needs the estrogen. So yes, go ahead and treat the vagina, but also treat the vulva, treat the area around, particularly the opening of the vagina, just in and just outside the opening of the vagina. Really, really helpful to treat that area, because that's often where a lot of the dryness occurs. So in summary for estrogen, so like I said, there's both the whole body estrogen and local estrogen. So the local estrogen is the vaginal estrogen, vaginal and vulvar estrogen that can be started at any age. Very little is absorbed by the body, and it works very well for vaginal and bladder symptoms. But it's best when it's started early. The longer you've had a problem leading up to it, the longer it's going to take for it to improve. And it may or may not ever get back to, like, quote unquote normal, depending on how much the tissues have shrunk and dried and gotten a lot more tight. It's a lot harder to kind of get them back. So if you're starting to have symptoms, start early. Get yourself checked to make sure it's nothing else. But then once you've made sure that it's nothing else, then to start some vaginal estrogen, and it can make a huge difference. So that's the local estrogen, and then there's also the topical estrogen. So that, or sorry, the systemic estrogen. So the whole body estrogen, which can either be topical, so that's the patches and the gels. It needs to be started in the window of opportunity. It must be taken with a progestin to protect the uterus from uterine cancer. There is no increased risk of blood clot with the topical estrogens, the ones that are applied through the skin. But there, but then the oral estrogen, there is a slight increased risk of blood clot. To just be aware of that. It can lower testosterone levels a little bit. Um, it needs to be taken with a progestin because it's the whole body estrogen, and it needs to be started in the window of opportunity. The primary things that are helpful there is convenience, and there's a lot of combo products that are available with that as well. And then so just finally, just a few words about testosterone. So this is kind of just this is a newer, more emerging kind of area. Currently, testosterone is only approved for the treatment of hypoactive sexual desire disorder. And even the evidence, so apparently the data show one additional sexually satisfying event per month. So like, wow, impressive. But anyway, but what's interesting is, so it's been studied for this, but there's clinical evidence, like a lot of women will report, myself included, will feel better. Like just like I personally noticed less brain fog, sleeping improved, like mood improved. Like I did notice it wasn't, there was these subtle differences that I felt a little bit more like myself. The evidence doesn't currently tell us that we don't have enough evidence to say that it's helpful for those things yet. But I will be very curious if we see more evidence to that effect in the coming years. But currently, it's only approved for hypoactive sexual desire disorder. Potential side effects are acne and increased hair growth at the site of application. It is, so this one, so you have to be very careful not to use too much, because if you use too much, you can get irreversible changes like clitoromegaly, like growing a small penis, voice changes, hair growth where you don't want it, that kind of thing. So you want to make sure you're staying in the female specific dose. So you do want lab testing. So this is one of the places we do testing. If you are going to be on testosterone, you are going to want it. Not only is lab monitoring recommended, it, like, I would say it's imperative. It does need to be done. I would not, it'd be really risky to take it without. So I would get a baseline to make sure to see what your testosterone level is, and then check it again 2 to 3 months after starting it, and after any dose change, and then every 6 to 12 months. If there's any side effects, doing it sooner. And then the things that you would want to check is a total testosterone, a sex hormone binding globulin level, and then the free testosterone or the free androgen index, which tells it. And you want to aim for about the mid to upper limit of the normal range for women. Typical doses would be, so there is no commercially available dose of testosterone for women in Canada. The only country that has it currently, to my understanding, is Australia. I suspect in the coming years we will see some testosterone, commercially available testosterone for women being available, but it's not currently. So I get compounded. So I get, like, because you can do like 1/10 of a packet of androgel, of the lowest dose of androgel, but to me that would be really hard to do, to figure out how to do 1/10 of a little tiny packet of gel. So I have mine compounded by a pharmacy, and I take 2 milligrams a day. The typical dose would be 2.5, anywhere from 1 to 5. Often, sort of 2 to 5 is what the range is for the HSDD. But if you're just sort of supplementing a little bit, you can even start at 1 or 2 milligrams. Typically applied to the inner thigh, and like I said, lab monitoring, really, really important. So, in summary, for most women, menopause hormone therapy is safe and effective for menopause symptoms. Systemic hormones, like whole body hormones, need to be started within the window of opportunity, or they can be started outside it, but ideally are started within the window of opportunity, which is within 10 years of last menstrual period, and under the age of 60. They can be started outside this window, but they do potentially come with more risks if they do. So it does need to be an informed risk discussion. Women with a uterus must use a progestin to protect their uterus if they're also taking estrogen. Vaginal estrogen is safe and effective and can be started at any age for local symptoms. And testosterone is currently only indicated for hyposexual desire disorder. And although it'll be interesting to see what emerges in the coming years, I suspect it might be used, have greater indications, but it's currently only indicated for HSDD. And if you do choose to take testosterone, you do want to do lab monitoring, and you're monitored clinically and laboratory monitoring to make sure you're staying in the female specific dose. And so I hope that's been effective, and I hope that's been helpful for you to get a high level overview of hormone basics. And what I also want to do is I just want to take a moment to talk about menopause as a time of transition. This is probably my key message is that menopause is a time of transition, and that this isn't something that's happening to us. It's something that's happening for us so that we can move, so that it's life shining a bright light on the parts of our lives that aren't working, so we can make different choices that are more aligned with who we really are, so that we can so that we can emerge from this time of transition as the matriarchs, the elders, the wise women that our world so desperately needs. And so I really want to bring home, and although I've spent most of this video talking about hormones, hormones are helpful. I am so grateful to my hormones. I love that I have access to this tool to help me through. And I am equally, if not more important, has been working my way through menopause as this time of transformation. And so to that end, I've actually created a course called Empowered Menopause. This is the first video in that course. But in that video, so in part one, what I do is I get into a lot more of, so there's 6 supplementary videos that go along with it, where I get into more detail, not just, so this video was meant to give you like Dr. Johnston telling you what she's learned from reading the science, doing like, this is meant to feed your head. This is to give you information. In the supplementary videos, Shayna is there. You're going to hear from Shayna and her personal experiences. So as I'm going to share with you my experiences with progesterone and with estrogen and with testosterone. I'm going to share with you more about the physiology, but really in a really kind of talking to you about it from my heart. I am going to also get into more details on the safety, some of the safety considerations for hormones. That's in there as well. And I'm going to just, what I hope you'll come away with is sort of a message of empowerment from that. So part one is focused mostly on hormones and on hormone basics, giving both information but also some heart-based, like it's meant to be like from one woman to another, that I hope what you'll come away from is that I'm sharing with you from my heart about my lived experience of the things that I've found have worked, and some of the challenges that I've had, and some of the things that I'm learning that are helping me to navigate this hormonal roller coaster, in the hopes that they will help you. And so yeah, in part one, it's mainly about hormones and some of my experience with it and some of my insights and some of the things that I've learned. And then also in part one, there's in both part one and part two, I've also included a recording of a video of a talk I've given a couple times on menopause as a portal to our wisdom years. So that's included in both part one and part two. In part two of my Empowered Menopause course, which is the one that's meant to go with the Navigating Menopause Together part of my group medical visits, what I'm doing in that one, I call it sleep, sex, and self-care. So what I'm doing in that one is talking about my own experiences with some of the challenges that I've had as I've been navigating menopause, and the things that I've learned. And then the whole idea is to bring women together to have these conversations together. So in the video series, I talk to you about, so there's again a video with slides at the beginning. And then then there's 6 supplementary videos where I go in and give you a bit more of even the behind the scenes. Again, like Shayna, so Dr. Johnston talking to you first, and then Shayna is talking to you, a woman who's had a rough experience of a menopause transition, who's here to share some of the things that I've learned, in the hopes that they'll help you. And so that's in the second part. I do a lot of just kind of, so I'll be talking about nervous system regulation and emotions and boundaries and sleep, sex, self-compassion, and connecting to our inner wisdom. So those are some of the things that I talk about in part two. And so And then for those of you who live in BC, this is also a two-part group medical visit. So you'll buy the recorded content, because that's not covered by MSP. You'll buy the recorded content, and then when we come together, the groups themselves are covered by MSP and by Menopause. So what you'll do is you'll register for those. We'll have 90 minutes together. In the hormone basics one, you'll have a chance to ask questions, and then we'll have some discussion about basically about hormones, and mostly it's me answering your questions in part one. And in part two, it's us coming together as women in community, having those heart-centered discussions about like what it's really like, and learn, like, to both share our challenges, but also to learn from each other and the wisdom of the collective, and to feel that sense that A, we're not broken, and B, we're not alone. And that's what I'm hoping that you'll come away with more than anything else from this series. And so if you're from BC, I invite you to come and join me for my two-part group medical visit. If you're outside BC, then the recorded content is available to you for purchase on my website. And so I'm hoping that this will be helpful for you, because underneath it all, I'm coming to you with an energy of wanting to be of service, of wanting to share the challenges that I've had and what I've learned from them, in the hopes that they will help you through this transition. And so I hope you'll find this helpful. And if you are looking to find any more information about me, the QR code will take you to my website, and this is the URL for my website. And I look forward to being able to meet you in my groups, or to be able to serve you in some way. All the best.